It's a pleasure today to have two fabulous speakers with us to talk about the issue of racial and ethnic health disparities. Dr. Sara Gehlert is the E. Desmond Lee Professor of Racial and Ethnic Diversity at the Brown School and the Department of Surgery at Washington University in St. Louis. She's the co-program leader of the Prevention and Control Program of the Siteman Cancer Center and co-director of the Transdisciplinary Center on Energetics and Cancer. She serves on the executive committee of the university's Institute for Clinical and Translational Science and co-chairs its Center for Community Engaged Research. Dr. Gehlert's publications focus on social influences of health, and she currently is working on the influences of neighborhood and community violence and unsafe housing on psychosocial functioning among African American women newly diagnosed with breast cancer. She's a member of the Board of Scientific Counselors at the National Human Genome Research Institute at NIH, and is a chartered member of the NIH's Community Level Health Promotion Scientific Review Panel. Our second speaker today will be Dr. Katherine Mathews. Katherine works as the Director of Clinical Services at Casa de Salud, where she oversees clinical operations and student internships and educational partnerships. CASA is currently conducting a Missouri Foundation for Health funded 2-year needs assessment among members of the region's Latino community. As an obstetrician gynecologist with a background in public health, academic medicine, and healthcare administration, she's dedicated her career to enhancing delivery of high-quality, evidence-based, and cost-effective healthcare with a particular focus on low-income and minority populations. She's lived and worked in the St. Louis, Missouri region since '98 and served as full-time faculty at Washington University School of Medicine from 2000 to 2010. From 2000 to 2006, she built the Siteman Cancer Center's public health programs and developed innovative approaches to enhancing minority participation in cancer research. From 2006 to 2010, she served as Chief Medical Officer at St. Louis Connect Care, which is the specialty care organization of the region's safety net, and was co-director of WashU's Center for Community-Based Research. So please join me in welcoming Dr. Sara Gehlert.
So good afternoon. I guess it's still morning, actually. But I'm originally from Missouri. I can't pronounce it the other way. I try, but my mouth won't do it. I have 2 master's degrees from Mizzou, and then I went off to that other school in St. Louis, Washington University, to get a PhD, and moved on to the University of Chicago for 19 years. And this is important only because I'm back at Washington University now. I'm in Missouri. I've been here for 2 years, but I'm going to talk about work that started on the south side of Chicago about a specific health disparity, breast cancer mortality. And then I'm going to tell you how we're trying to implement our findings from Chicago in St. Louis with a dream of moving to rural Missouri. And it is an example of team-based research. We talked about other team-based approaches. This is a team-based approach to research. So, just one slide on background on health disparities before Tom talks. Health disparities occur by race, ethnicity, sex, socioeconomic status, and geographic location. Rural versus urban mainly. They occur in health and healthcare. They're seen in the rates and quality of screening, incidence, treatment, and mortality across a number of diseases and conditions in all parts of the world. My focus has been on black-white breast cancer disparities. And to give you some background, from the time that the National Cancer Institute began to collect statistics by race in the early 70s till present, white women have been more likely to get breast cancer. And if you look, the gap between black and white women in incidence of breast cancer stayed about the same. But what's alarming is that the picture isn't the same for mortality. So although black and white women were about the same till the mid-90s, at that point, a gap began to form, and the gap has not been closing. So that nationally, black women who get breast cancer are 37% more likely to die from it than white women. And we could talk the whole time on this slide, but basically the situation has improved for white women and there hasn't been concomitant improvement for African American women. So if you look at Missouri, you see that this is mortality from breast cancer, and again from 1975 to present. And what's alarming to me is that breast cancer mortality is highest when you divide by Missouri black-white and U.S. black-white, and then compare those four groups. The highest mortality is for black women in Missouri. The second highest is black women in the United States, and then white women in Missouri and white women in the United States. And as if that were not bad enough, we see an improvement in the other three groups, but we don't see the rates going down among black women in Missouri that we see in the other groups. So I'm going to get back to Missouri. I'm going to move to Chicago now. We're going up I-55 pretty soon. So because of this, because we really weren't getting at health disparities well, we weren't making improvement, NIH decided to try to put money into new approaches to addressing health disparities, and one of the first that was funded in 2003 was the Centers for Population Health and Health Disparities Initiative. They put $80 million into these approaches that brought together for the first time scientists from a lot of disciplines and community members working in concert. So as I said, they were established in 2003. They were directed at health disparities. They funded 8 in the first round. I was principal investigator of the one at the University of Chicago, each with 3 interdependent research projects addressing biological, behavioral, and social aspects, not separately the way we used to do it, but using a shared model and answering the same question. So when I first got a center grant, I won't tell you how many years ago, you would come together, the scientists would come together, and you'd kind of shake hands and you'd hug at the beginning, and then you'd go off and everybody would do their separate studies. So the biologist, if there was a biologist, would go to the lab, the sociologist, social worker would be out in the community, and so on and so forth. You'd come together at the end with your results and you'd try to make them fit, and they wouldn't. And then when you'd try to turn it into programs and practices, it wouldn't work. So trying this new approach, which was one of the hardest but the most wonderful things I've ever done, and we put out this report in 2007 called Cells to Society. So what influences cancer risk? We know at the macro level, regulations, policies, societal views, genetic factors, inherited mutations, spontaneous mutations. At the individual level, diet, physical activity. We tend to focus mostly on this. The meso level, new data on early family relationships in adult cancer, and demographic factors. So my point is all these things influence cancer and influence disparities, and we can't look at them separately. We've got to consider that whole person in the middle. So my colleagues and I, the principal investigators of the Centers for Population Health and Health Disparities, published this in the American Journal of Public Health in 2008, and I think it's a little outdated now, but it's a frame to remind you that in order to capture a complex phenomenon like cancer, you really got to consider all the things that make it complex. So that goes from biologic genetic pathways to individual risk factors, to social relationships, social networks, social support. Neighborhoods are very important. It's become the center of my work when I never thought it would. Collective efficacy, segregation, neighborhood disadvantage, institutions, healthcare systems, social conditions, racism, sexism, discrimination. So we talk about upstream and downstream factors. They all interact. If I was doing this now, you'd need 3D glasses because it can't be done in 2 dimensions. All of these things interact to influence disparities. So we started this center at the University of Chicago. That was in 3 places: at the Cancer Risk Clinic, in the Institute for Mind Biology, which is neutral space. If you want to work across schools and divisions and disciplines, you've got to have a neutral space. So one isn't privileged over others. If the grant is administered in the medical school, if it's administered in arts and sciences, they by almost definition will have more power. So we had it administered through the Institute for Mind and Biology. We're also in Ibadan, Nigeria, but I'm not going to talk about that today. But the point is, I was PI I'm a social worker and an anthropologist by training. Martha McClintock led one of the research projects. She's a biological psychologist. Suzanne Kanzen led another one. She's a breast oncologist who's also a molecular biologist. Fumi Olopade is the director of the High Risk Breast Clinic. She's also a geneticist of primarily breast cancer for women from with ancestry from West Africa. She won a MacArthur Genius Award for her work. And Tomasz Kraus was the chair of surgical pathology. So this was a group that had never worked together before, but that came together because we shared a research question, and that research question was, how do factors in women's social environments contribute to the African American and white disparity in breast cancer mortality? And the clinicians were there because they knew from working on the south side of Chicago that they weren't going to come up with a drug that was going to eliminate disparities in breast cancer. They knew that there were social conditions. They could not work there and not know it. Even the pathologist, excuse me, if they're pathologists, I didn't mean to say even the pathologist, but the pathologist realized. So we all really had this question in the back of our minds. And it's interesting to note, we know that it can't all be biology because you see different black-white disparities rates in different cities in the United States. So we know that it's, I told you, about 37% higher for African American women, 1.37 on here then, for the U.S. as a whole. But in Memphis, it's an African American woman with breast cancer is twice as likely to die than a white woman. Whereas in San Francisco, there really isn't a difference. So what's going on that it would be so different across cities in the U.S.? Chicago is particularly high, which is why we were doing what we were doing. Biology, probably not, because not much of breast cancer is really hereditary or due to Mendelian inheritance. 70 to 80% of breast cancers are due to sporadic mutations that happen across the life cycle. Only about 5 to 10% are due to known inherited mutations, BRCA1, BRCA2 among them, and then about 15 to 20% more is clusters of women and families who we think probably have some biological basis for their breast cancer, but we haven't been able to put our finger on what it is. So our model, when we all came together, all these scientists from different disciplines, was that in our sample, race didn't equal biology, and it shouldn't be an equal sign, but basically what we were trying to say is that race in the United States does a lot to determine the social circumstances in which people live. And that leads to certain psychological states, which leads to neuroendocrine and gene expression changes, which leads to malignant cell survival and tumor growth. We all are sitting here having little mutations, but in a healthy organism, they're repaired. So we were working from social process to gene, and you can see why no one discipline could do this whole thing. So you can map what each of us was doing across the model. And if any of us had stepped out, we couldn't have answered the question. So this is what we put together. It really was a mutually informative, multi-level, and multimodal approach. So 2 projects worked with animal models, a Sprague Dolly rat model and a TAG transgenic mouse model, SV40. And Fumi Olopade and I worked with the same groups of women in Nigeria and on the south side of Chicago. And we were working with women who were newly diagnosed in clinics at the University of Chicago Hospital, Stroger Hospital, which used to be called Cook County Hospital, and Mount Sinai Hospital. So 3 hospitals on the south side. And together, we were able to consider variables and their mutual influences from the community neighborhood level. We looked at crime. We were able to get crime statistics from the city of Chicago and come up with buffer zones, quarter-mile buffer zones around each woman in the study so we could compare them in terms of the crimes that they were experiencing in their neighborhoods. Collective efficacy, social ecology of neighborhoods, to housing, environmental exposure, to social circumstances, especially social isolation and social support, to psychological states, behavior patterns, to hormones, to genes. So among us, we were able to do this. and the animal model provided part of it. So I'm going to give you just quick background on the animal model. Basically, Martha McClintock works with Sprague Dawley rats. She manipulates the social conditions. They're called open caging. She never puts a catheter in a rat. She never gives a rat any substance. She just manipulates social conditions, especially whether they're like this or whether they're alone, and then looks at the effect on biology. She's championed this. So these are female rats. If you left them, this is their ideal world, basically, piled on top of one another. This is the preferred position. That rat gets to spend, I don't remember how much time in that position, and then has to rotate, but it's a happy rat. So what Martha does to stress the rats, and think about this in terms of humans, is she takes them out of their social grouping, puts them in a cage alone for certain periods of time during the life cycle. And one reason we work with the rodents is that they live 900 days. And so you can take a lifespan approach, which is important, and also you can manipulate social conditions, which you would not ever want to do with humans. So it's a pretty good model. So they're in the same room, they just might be in a cage alone instead of in their happy group. So what Martha found right off the bat, this is some special software. You're looking down from the top into the cage. And that's an overturned food dish, which is a novel stimulus, which should interest the rats. And the blue is a little software program that tracks the footprints of an individual animal over 24 hours. So these are the animals that were left in the happy group, and these were the animals that were isolated. And what we found was that at 20 days of age, the ones that were group housed explored their environments, which is healthy. They looked for food, they looked for affiliation from other rats. But the animals that were left alone, especially the ones that were left alone the longest or during the period of puberty, just stood in the corner and looked around for threats. They didn't know how to interact with other rats when they were put back in the social group. And it didn't undo itself. Okay, so we saw these two groups. And then when we followed them, and the group house rats looked fine. These are two sisters that are genetically as similar as humanly possible, but the rat that was isolated quit grooming and began to develop these spontaneous mammary tumors. And the pathologists at first said, yeah, but they're not malignant. But they were. They were malignant in about the same percentage that you see in women. We sent them to NIH and said, can you help us figure out which human categorization scheme we should use? And they called back and said, Dr. Gehlert, you're on your own. We have no idea. We don't ever do that. So we saw then that the tumor burden of the animals that we isolated was 83 times higher than the age-matched control, which was the group-housed animals. So we knew we were onto something. So Suzanne Konzen, the molecular biologist / breast oncologist, was doing work with stress hormone. So we thought, well, let's see if the stress system is how this worked. So all we did was move the cage of the isolated rats and the group-housed rats about a foot away. A very mild stressor. And then we measured the stress hormone levels before, 30 minutes after, 90 minutes after, 150. And we then looked at how fast the stress hormone went up and how it recovered. And basically what we found was that the group-housed animals kind of did what you learned in psychology as an undergraduate. They responded to stress by putting out stress hormones. But the animals that were isolated, stress levels went up, and it took much longer to recover. And being exposed to that is not good. So one of Martha McClintock's postdocs was able to predict when the tumors developed by the rise and when the animal died by the recovery. So we knew again we were onto something. We're looking for a pathway. How does the social environment get under the skin to change biology? So this is my last heavy biological slide, I promise. But this is from the SV40 tagged transgenic mice. And I'm trying to make the point that in normal tissue, you see stress hormone receptors to deal with stress kind of scattered around. But in invasive, they were in every cell. And so you get this organism's trying to deal with stress. It's trying its very best to deal with stress. But at the same time, estrogen receptors and progesterone receptors, and I'm getting to why this is important, I promise, started to vanish. So there was a crossover. As stress increased, you got less reproductive hormone expression. Have you heard of triple-negative breast cancer? It's bad. So this is the significance for women. Believe me, it's how I spend my life. It's horrible, and it explains a lot about the black-white breast cancer mortality. So estrogen receptor negative and progesterone receptor negative breast cancers are much more aggressive. We work in Nigeria. In Nigeria, it's known as a disease of young women that's fatal. These tumors grow very fast. These breast cancers are harder to treat with existing chemotherapy agents, and ER and PR breast cancers have significantly lower 5-year survival rates, and the mortality from triple negative, when you also throw in a third hormone receptor, is twice as high as non-triple negative breast cancers. And we know that these kinds of cancers are much more prevalent among African American women. There's not been enough money to see about Latinos, to see about Arab Americans, but this we know. So we were focusing on the south side of Chicago. Chicago's in neighborhood areas, and we were focusing on those who were primarily African American. Now, important to know, the University of Chicago hospitals there, important to know that there's a lot of socioeconomic diversity here. This is Brownsville, Kenwood, where the Obamas live, Minister Farrakhan lives, Muhammad Ali used to live up here. Englewood is where Jennifer Hudson's family was killed. A lot of diversity, high African American residents, but a lot of diversity in socioeconomic status. So this is the approach we took. We decided we would go into the home and interview women. I'm not going to give you the list of measures we used because we don't have time, but we interviewed them in their homes. Well, first of all, when they had surgery, Fumio Lopade's lab went in to get extra tissue. My group then went into the women's homes 4 to 6 weeks after surgery. They were kind enough to invite us in. 86% of the women we asked invited us into their homes. They were wonderful. We looked at psychosocial functioning, social network, health behaviors, perceived discrimination. So we did salivary cortisol to measure reactive stress. So that's stress the woman was experiencing on that day. And then we did allostatic load, which is kind of lifelong stress. We did the community level variables geocoded, like I told you, so we had a quarter mount. I think I've got a slide of it. But it still wasn't enough. These measures were too crude. So we added a third team, which was a neighborhood team, a built environment team. We mapped the 4-block area, everything on it, around each woman's home. We looked for things that would foster social affiliation, like blocks where people could come together and have picnics, or vacant lots that were full of drugs and syringes. We looked at, sorry, I can't show you some slides from Homewood and Pittsburgh that are pretty amazing on just what neighborhoods are like in terms of boarded up buildings and how it changes the character. But we had these data on each woman in the study, and we followed each for about a year and a half. Some women, unfortunately, didn't live that long, but we used African American master's level social work interviewers who grew up in the neighborhood. So this is just something to replace about 10 slides, but I had this on my desk one day, which is a slide I showed you before. And I had this on my desk, which was one of the students from geography at U of C who was just mapping a neighborhood. And this is a pretty good vacant lot. This was used for softball. And this was something I had on my desk, which was a satellite map of one 4-block area around a woman's home. And it occurred to me that in the same way we manipulate social conditions with the animals to produce the tumors, neighborhoods can change biology by manipulating the lives of women and their psychological response. So we had women who told us that they were never able to sleep through the night. They always had to keep an eye open or an ear open. And these were the women who, when we measured, and I had to leave these slides out, but had given up responding to stress. They were totally flatlined. And when we asked those women when we looked back at the responses, we said, what are the worst things happening in your life? Breast cancer was the third or fourth worst thing. Wasn't even the worst thing. It was finding housing for my children. So by working together, we were able to go from the population level, looking at social isolation and neighborhood factors in my work, to the individual level, looking at acquired vigilance. We called it neuroendocrine response in the animal work in mine, and looking at the tumor level for these more aggressive tumors. We weren't predicting if a woman got breast cancer, we were predicting if it was triple negative through Fumi's work and the others' work. So this is something we're just publishing. We were able to predict from the women's data whether or not she had triple negative breast cancer from models in which, I'm not putting the whole model down because I hate it when people put like 500 words in a slide, but from age, her mother's education, which is a measure of what her life was like, how long the adversity might have been going on, and from discrimination. And that's pretty amazing. So we're able to, through pathways and stresses in here, an altered stress response, go from basically the social environment to changes in biology. Okay, so how do we deal with this? It's wonderful to know. So basically we're trying to translate this. We're working, first of all, from Suzanne Konzen's work to build on these molecular pathways we found that I didn't really talk about, targets for breast cancer prevention. But because we found among women decreased or increased social isolation and feelings of anomie, just feeling you didn't belong anywhere, we're looking for interventions that increase social support and build social network. So we're testing a neighborhood-level intervention, and we hope to have a neighborhood intervention to improve clinical and biological outcomes, working upstream. Some of the community-level interventions that we think might work are reclaiming existing spaces, these spaces that are just so dangerous, so nefarious. We had a New York Times journalist in who wanted to see our neighborhood work, and she tripped across, we were walking across a field, across a bag of medical waste that had just been thrown off an ambulance in Englewood because people just don't value the neighborhood. So it's a big bag of urine in a place where kids might be playing. So we're trying to look at vacant building receivership laws. And most cities have these, like if a building isn't taken care of, the city can take it. But paradoxically, a city like East St. Louis or Gary doesn't have the infrastructure that they need to handle this, because you've got to follow who owns the building, you've got to go to court, they just can't do it. So the places where it's most needed, it's happening least often. Developing social networks through block clubs is another way of doing it, and I'm glossing over this greatly, but Cleveland established Cleveland Housing Court with tighter control over properties, owners, and code enforcement, and they've really been turning over properties. That's the model. Cleveland's the place that does it well. So one thing that happened was, I've learned that if you want to change something like disparities, you can't just do your research. So even when we didn't have time to do it, we presented it. We presented it in forums, and we invited other universities, we invited the state and city departments of health, we invited stakeholders, we invited federally qualified health clinics, we invited anybody who would come. And we were downtown so people could get there. And we presented the results enough with the purpose of influencing breast cancer policy at the local and state levels that ultimately, and it was totally out of my hands by then because it had developed momentum, women were mad, and families were mad, and everybody was mad. The 2009 Illinois Breast Cancer Disparities Act, which was House Bill 5192. And this was nice because it increased Medicaid reimbursement rates for screening and mammography to Medicare levels. So you found community clinics that were doing most of the screening, and you had an overworked mammographer who had piles of films. And if they weren't digital, so if they saw something wrong that was suspicious, and remember this early, quick-growing tumor, they had nobody to ask for a second opinion. They couldn't zap it to Northwestern or University of Chicago for a second opinion. Well, we were able to, in this law, reimburse the places that improved at 3 times higher rate, because Medicare rates are 3 times higher than Medicaid in Illinois, and that allowed them to build the infrastructure to be able to do higher quality mammograms. Also, it increased access to screening, and it eliminated copays, and it covered pain medication for women undergoing outpatient, including mammography, because it's still the case we see at Siteman that women don't get mammograms because they're afraid that they will be painful. And apparently some talk show host, African-American talk show host, had a mammogram on her show and screamed her head off during it, which has got all our breast navigators really upset. Wasn't a good thing. So we're trying to move this. We have money from Susan G. Komen from McCure. We're doing a community-based participatory project in St. Louis with People's Health Center, a federally qualified health center, the largest, with St. Louis Effort for Age, which may seem odd, but they have a women's wellness van on the north side of St. Louis that has rapport that will help us get to the women who just are the most difficult with whom to communicate. And Susan G. Komen at Siteman Cancer Center, Christian Hospital, and Committed Caring Faith Community, which is a group of African-American, mostly African-American clergy that are interested in health. And the project has the purpose of understanding how gaps in the provision of services to women in North St. Louis contribute to the African-American and white disparity there, which is huge. I'm going to show you in a minute. So we are all the people who provide services to women once they get an abnormal mammogram. So my idea was in Chicago there were 55 and you couldn't get them together, but we're all partners and we sit down and look in our own databases and see how we are moving women among ourselves. It's not just, within Siteman, within Barnes Jewish Hospital, we're not terribly good at moving women from surgery clinic to radiation oncology. So it's, believe me, we need to be remedied as much as anyone. So this is just the city of St. Louis. This is about Highway 40, that's Forest Park. This is breast cancer mortality and zip codes. The breast cancer mortality is much higher on the north side of St. Louis. This is in Mississippi, of course. And just these two zip codes, this is primarily African American, this is primarily white. Look at the difference in deaths from breast cancer per 100,000 population between these two contiguous zip codes. This is just unacceptable. So we're working with 8 zip codes. I like a geographic approach. Our office is right here in 63115. We're working in the 8 zip codes and we're asking women who were diagnosed between 2000 and 2008 living in these 8 zip codes to talk to us. And the response has been pretty good. We're waiting for Mizzou IRB approval, for one thing. Okay, so this is just our staff. This is our office. We have a resource center, 3335 North Union, where we're just trying to be there to answer questions 8 hours a day. These are 2 young men who volunteer. We, in terms of, we know it can't just be breast cancer. It shouldn't just be breast cancer, so we have a tutoring program for middle school because students came by and wanted to use the computers, and then we got the Black Student Association, Undergraduate Association, to do the tutoring. That's worked nicely, preparing them for careers in health disparities. We have a clothing closet. We have programs on nutrition from University of Missouri Extension, and we have programs on physical fitness, and St. Louis Effort for AIDS does HIV testing. So this is how we're trying to approach one disparity. Thank you.
I have to do something radical.
And now Katherine will be doing something radical.
No, I wanted to show one of your slides. That's what's radical. So I was not intending to start my presentation with Sarah's slides, but it does connect to what I wanted to talk about. And I will lead in officially, but just by way of introduction or acknowledgement to my presentation. When I came to St. Louis in 1998, I was not interested in breast cancer. And the person who assigned me this work is Cheryl Jackson. She's a breast cancer survivor. She's how I met Michael Raley way back when. She had just started a breast cancer support group, and we were working together in a clinic in North St. Louis. And I say that because what I'm going to talk about is how we make positive social change. And when I think about the impact that Cheryl has had on my life, but actually the entire university and community and Komen at a national level, this is one person who has made profound change around breast cancer and how we understand it in African American women. So that's my shout out to Cheryl.
She's probably feeling something positive right now.
All right. So I wanted to talk about three things. You've heard a little bit about Casa de Salud, and I wanted to back up and talk a little bit about the history. I then wanted to talk about the stakeholders who were involved in CASA forming and the stakeholders that we work with now. And I wanted to finish up by talking some about our Missouri Foundation for Health funded needs assessment project, what we call Salud de Nuestra Población. And I have some team members in the room on that. And the reason I want to go through the talk in this way is that I want to do something that I think of as being unusual for health disparities and health equities conversations. I want to talk about power, influence, and authority. So to start with CASA, and I'm just going to flip through some pictures. This one, okay. And I've got this nice little transition that I hope won't be too distracting. So here's our public face. Just right up front, you can see that we've got a St. Louis University logo on us. And here's a lot of our main teams. So we've got Maria, who's in the back of the room. I'm embarrassing you. We've got our executive director, Jorge Rio Pedre. I'm not in the picture because actually at CASA I keep more of a low profile than I've had in other jobs. And somehow I think I was back at my computer at this point. Our first speaker this morning talked about our behavioral health program that's headed by Ann Farina, and our social work involvement, that's Fernando Mena, who actually used to work with St. Louis Effort for AIDS, and he does a lot of our referrals and is helping us with clinic management. So the story behind CASA is that this is a relatively new organization. For those of you who are from St. Louis, you know we had two other organizations in town, and the one where I had worked a long time ago was called La Clínica. And I had volunteered there back in the spring of 2001, I believe. And La Clínica was serving Spanish-speaking clients in the region. And I, even though I was only there briefly, I had a very strong sense of connection to La Clínica. We have other La Clínica people in the room. And I, at that time, was only doing a little bit of patient care. This is about 3 years ago, with La Clínica was still open. And even though I didn't have a role with La Clínica, I felt very connected because I was getting referrals to St. Louis Connect Care to see patients. And so I was having women from La Clínica come, and I was able to use my clinical Spanish some. And this was a very painful set of memories to me because I decided to go to Mexico to work on my medical Spanish in March of 2009. And I got back, and within a couple weeks, La Clínica had closed. There had been tremendous effort at the end of La Clínica's existence to keep it open. And there are many, many different understandings of what happened. But here was a place where people went for care, felt welcomed, felt respected, and all of a sudden it wasn't there anymore. So here is this strange set of stakeholder conversations that begin to come into play. The person who was holding together La Clínica at the very end was a woman named Marianne Cook. And she was very close friends with Bob Fox, and you may not know Bob's name, but Bob's wife is Maxine Clark, who founded and runs Build-A-Bear. So all of a sudden we've got kind of a corporate high-level couple that was interested in this organization and was fairly distraught that it had folded. On the other hand, there were a number of students who volunteered at La Clínica, and in particular there were a number of students from St. Louis University. And they were also quite distraught because this was a place where they could learn and provide service. And so as I understand the story, and I feel like in St. Louis there's never one version of a story, but all the stories together somehow paint a picture of what might have happened. As I understand it, on one hand, Bob Fox came to Marianne Cook and said, "Why didn't you tell us you needed help?" And on the other hand, the students came to Father Biondi, who's president of St. Louis University, Jesuit University, and said, "Father Biondi, this is not okay. Patients need a place to go. This was an important service opportunity for us. You need to do something." So Bob Fox is on the board of trustees for St. Louis University. He has connections to Biondi. And because of those stakeholder connections, conversations began almost immediately. about forming a replacement organization, so that by July of that year, 2009, Marianne said to me, I can tell you now, it's public information. There's going to be a replacement organization for La Clínica, and it's going to be called Casa de Salud, and SLU, as you saw by that logo, is going to provide a lot of support. So I'm going to wrap back to this stakeholder issue after I show you a few more pictures. So here's Diana Llamas. Diana is Peruvian, grew up in Spain, and was our lead nurse. And she was with us through the fall, and this is one of our clients. We have recently done a build out, and so you can see that this space is quite appealing. Bob Fox runs his own company called New Space, so he's very attentive to physical space and what it communicates. This was not designed by someone who's an operations expert, so I can't say that we have the fastest track through clinic, but it's beautiful space. This was a community open house we had, I lose track, sometime over the winter. And then here, this is as data-y as I'm going to get. And this relates to the project I'm going to talk about at the end. But these are our intake forms based on new patients. We've been doing this. We started last summer. So here's the age distribution of the women we're seeing, the men we're seeing. We are seeing, we are seeing slightly more men than women. Since it's hard to have very accurate census data on this population, I can't tell you whether men are over or underrepresented. But if you compare it to St. Louis Metro in general, our clinic sees more men than you would see in the overarching base population. And then we're drawing from quite far away. So the last time we did this analysis, we were drawing from 9 counties in Missouri and 2 in Illinois. And here's our close-up of where we are in the metro area, which interestingly, you'll see is a flip of the map that Sarah was showing. So her map showed you where the African-American communities are. My map shows you that the Latino community, at least in the city clusters down here. So CASA then opened for business in January 2010, and the goal was to do things a little differently, and it's what I call negotiated space. So, and this is not a resolved conversation, so it's, I guess I would say it's a space that's still being negotiated. We have a number of healthcare organizations in the St. Louis region. We have 4 FQHCs in the city. We have a large FQHC on the other side of the river. Our county runs 3 primary care clinics, and then we have some other smaller entities that provide health care. And when CASA was forming, one group of folks were very outspoken that we needed a place for people to come and feel welcome and receive care in Spanish. And another group of folks, the existing safety net, positioned that we provide this care already. We don't need another competitor in the region. We particularly don't need you pulling money out of a fixed pool of funding, or a perceived to be fixed pool of funding. So the negotiated space for CASA has been that we welcome people in, and then we link, and it's more than link, we really go with people to other places where they need sources of care. And we do this through very strong referral coordination. I sit next to Fernando, who handles referrals, and I can tell which organization he's talking to because he speaks, he's very cordial and effective. He speaks differently to different people because he's flexing to who they are. And so I can tell by his tone of voice. I can tell by what policy issue he might be reminding them of, because somehow they seem to forget their policies. So we work referrals hard, and to thank Samantha for what she said, a big part of our networking function is that we know people in multiple organizations, and so if we're having trouble, we know where to go to advocate to get people in the door. And then the other big piece of this is that we have navigators, and this is a concept that actually grew out of the breast cancer world. I always think of it being Harold Freeman, Harlem Hospital, and African-American women, and the idea that these darn systems, and they are so complex and intimidating that you really need someone to walk with you. I mean, it's true for me as I try to use healthcare for my child. So imagine for our patient population. So we have people who go with our patients to other organizations. And they serve as advocates in the moment, but they also collect information, seemingly innocent information, like, did the receptionist smile when you walked in the door? How long did you have to wait between your arrival and your scheduled appointment time and when you were actually seen? How long were you there for your appointment? And when we compile this, across a number of different visits, we get out of that anecdote fighting, because we can say, well, gee, your average visit time on the weekends is 3 times your average visit time during the week. Did you know that? So that's another way in which we advocate as we're trying to create more receptive spaces into the other organizations. But to wrap back to this point about stakeholders, one of the things that was really striking to me when CASA was formed, and I'm not Latina, was that the people involved in the decision-making were our beloved board chair, Bob Fox, who's son of Polish immigrants, and Father Biondi, who's a Jesuit president of a university, and students who had a huge concern for the population. And even in our needs assessment project, we've actually gone and interviewed people who are in the social service sector and may identify as Latino, but aren't necessarily from Mexico, and that's the population that we're primarily serving. So we've spent a lot of time processing this engagement and this stakeholder question. And I guess the first part of the story, and I'm going to close with another piece of this, is that when we think about St. Louis and we think about positive social change, to think that we can create positive social change just by doing the right thing and not being strategic may only get us so far. So you heard about Sarah's examples where in the scientific world, they worked across multiple different groups of people. Or in Chicago, that they made sure they put out information to multiple stakeholder groups. And I would say, even though no one kind of sat down and said, okay, strategic plan for CASA, get a lot of people involved who have influence in the region, it's been an intuitive part of how we do things. And I think one thing that is also interesting to me, I came with my own set of networks, primarily North St. Louis, primarily WashU. Our executive director, Jorge Rio Pedre, was the founding, was most recent, prior to coming to CASA, he was president of the Hispanic Chamber of Commerce. He's got a huge set of networks. Bob Fox, huge set of networks. And that we use those networks all the time. So where does that put us? In some ways, it opens up tremendous opportunities. So I'm going to flip through. So, we have Bob Fox Day, which I think is October 14th, 2011. So this is a representative from Mayor Slay. I was surprised when I was going through our website and our Facebook page because I was looking for pictures. I thought, here I am, the only picture of me. I'm here talking with William Lacey Clay. So, it's interesting in that we have access to folks. Or one of the things that Bob in his own time Bob in his own time is doing is working with leadership from Emerson, the corporation, city, county, to talk about making it a more immigrant-friendly region. So very intentional use of networking and strategic engagement in kind of this unspoken about but always operating St. Louis political and social system. So that's, I think, an advantage to us. It opens doors for funding, it opens doors for being heard. I was pretty tickled yesterday when we got a call and said that the head of the Association of American Medical Colleges was coming by. So it creates some influence opportunities. But from an ethics point of view, and this was where my concern really kicked in. One reason I believe that I was so fortunate to do a lot of work around breast cancer was that the idea came from Cheryl Jackson, who is from St. Louis. And she was able to tell me that this was an area of need and ask me to help. I thought, wow, so we've got all these high-level stakeholders, but we've got power, we've got influence, but where's the authority? Where's the authority for what we're doing? And that was how we came about, and I think I have a few more pictures. That was how we came about. Maria, on the way here this morning, said, when did you start writing that grant to MFH? And I said, well, in my head, in January 2011, but I didn't open a Word document till May. That was when we began thinking about this needs assessment grant through Missouri Foundation for Health. And so to talk about that just briefly, and how much more time? Okay. And we're lucky in that we're working with a policy group at MFH, so we're not, we have some methodological freedoms, Sarah. So by which I mean, we intended to start out doing a bunch of key informant interviews and then moving to focus groups and then potentially doing survey work. But what our whole goal with this project is to be hearing from people in the community. We started out more in the professional sector. We're working now to hear more from people who are representative of the people we're serving. And through very open, semi-structured interviews, be hearing about all the things that have impact on health. We have folded in the quantitative stuff through this intake survey, so it's helpful for me to be able to tell you, gee, out of over 500 respondents, 90% of people come to us by car. Kind of interesting. But this whole approach with the Needs Assessment Project is how can we be in a listening position? And we think very much about what's the best listening position, because if we're coming as the authoritative researchers, that whole relationship may affect the kind of information we get. So how can we be in the best listening position? How can we ask questions in a way that doesn't presuppose certain answers, so that we are really casting a very wide net to figure out what is of most concern to people? And of the list of concern, what are the complexities? So for instance, just to go off on this transportation thing for a moment, there's a lot we don't know. We have a lot of questions, but if we're drawing people from as far as 2+ hours away, and in addition to locally, and 90% of people are coming by car, and we also know that driving, if you don't have legal status, is very dangerous, and that people don't necessarily have their own cars. That all the work around getting somewhere is much more complex than are we near the Metrolink or near a bus route. So the more we ask them, not only do we know the what, transportation, domestic violence, respect, and cultural competence, not only do we know the what, but we're really working to get this very detailed picture of how and why, and how is this a particular concern for a population, and how can we help the broader community really see and understand more clearly. Like Sarah's approach, we've been really intentional about bringing information out. So even though we're only 6 months into a 2-year project, we're already beginning to summarize quotes and themes, not to say that these will be the most important, but to kind of whet people's appetite on what we're hearing and what we're finding. The reason we're pushing this now is that, gee, the not-for-profit hospitals have to do community needs assessments. We wouldn't want them to think that we didn't have information available. So that whole, and in fact, part of how we wrote the grant was to get a number of entities to commit to hearing what we had to say, because if they listen, our hope is that we can create some obligation about how people might respond. So we do a lot on the individual level. We have compelling stories of individuals that we serve. We learn all the time from those experiences. I think our cases inform our thinking as much as these broader level initiatives. But we also feel that we have the opportunity to create this authority of a community, even if it's a community that for safety reasons needs to stay discreet, that we can create an authority about what we might do and what others might do by going out and talking and listening and learning and then figuring out the best ways to get that information out to our region for planning together on the best ways to create change. So that's what I wanted to share today, and I thank you for your attention.
For questions. So do we have any questions that anyone would like to ask of Dr. Mathews or Dr. Gehlert? I'm kind of curious as far as the implementation in the St. Louis area. What kind of time frame are you looking at as far as the community-based interventions?
Well, is this on? Okay. What I've learned is when you're doing community-based work, it's not going to happen fast. So we're in an area, the 63115 zip code, where people they don't know who we are. And so we're taking our time. We're providing services. We're doing presentations to any school, church, or community-based organization that asks. We've got Lannis Hall, who's a radiation oncologist, sorry. We've got a wonderful group of people that are willing to go out and speak. So we're trying to sort of take our time and not be interlopers. We don't want to helicopter in the language of CBPR. So we hope to, over the next 2 years, to have some information and begin to make change. St. Louis is a little bit, dare I say it, more difficult than Chicago. Not sure why, except in Chicago you have people behind you like Jesse Jackson Jr. and Michelle Obama, when she was the vice president of the University of Chicago Hospital, was helping us. That didn't hurt. And so in St. Louis, I don't know, maybe we could ask Dr. Ross and Dr. Rayleigh to comment, but
She'll be right there with the mic.
Oh, yeah. Were you saying it was?
no, just wondering what you thought.
Yeah. Okay. Yeah. St. Louis is weird.
I didn't want to say it myself.
Right where it is. St. Louis is weird. It's got this strange, what high school did you come from thing. We have these hierarchies that we put people in, and we resist letting those people break out of those hierarchies. You're either old money, no money, new money, and we don't want you to move in between that strata. And so as I was listening, I was really keying in on what you were saying so nicely. I said it much more harshly, is that we're just really strange, and I don't see how we're going to, I see ways that we can do it, but we need that kind of an advocate like Bob Fox and his wife were to come forward for African-American females, African-American males. I mean, you can pick any of them. Until we get those kind of advocates who have decided they have the passion, and then they have the money, and then they have the connectedness, which is what you were saying, we can't get past it. And somehow in St. Louis, it's hard to penetrate the grassroots. I mean, we have so many people with so many great intentions that is so difficult to get it to go down deep into the grassroots. So St. Louis is just really a different population to approach that requires some extreme thought processes and connections to try to overcome. I'd be happy. I know.
St. Louis in the house.
Yeah, I'll just take a couple of minutes. And St. Louis is strange for a reason. And Missouri is odd for a reason. And the people I talk to at the grassroots remind me of the history of St. Louis. And of decades ago, 1919, the horrible East St. Louis race riot, which really led to very entrenched neighborhoods. The restrictive covenants that were placed post-World War II, they remained in place up until 1972, really demarcating harsh boundaries, hard boundaries for North St. Louis, African Americans, South St. Louis, Germans on one side, Italians on the other side. These things were there, and they were pretty much driven by policy. And those who reside in those communities remember that history. And those of us who were outside of St. Louis, who are non-native St. Louisans, who are interested in community collaborations, need to understand that St. Louisans operate per this history. Therefore, we need to provide them a conceptual framework that allows them to transcend this history, to become more empowered. And I think that's what that is what we're hearing from our speakers here, because sure enough that you cannot ignore the harsh reality that life was imposed through these terrible incidents over the past 80 years in St. Louis. That's why St. Louis is strange.
And so it requires a really sort of humble, respectful approach. And no, Tom.
My name is Ruth Ramsey. I'm from Kansas City. I publish a magazine in Kansas City, Our Health Matters. I'm curious to know, with the study that you did, what was the state of mind of the women at the different periods of time after they received? Were many of these women, they were diagnosed, did they have mastectomies? Were there breast removals? How much work went into their mental state of mind afterwards? And are they being advocates, or is there any formation around getting them to be more public if they chose to do so?
Thank you for the question. It's a good question. We found really a lot of depression. And the University of Chicago Hospital, where I used to work, didn't want to screen for depression because they weren't sure they could provide the services. So we saw a lot of untreated depression. And when we looked at whether that depression was, much of it was tied to the breast cancer. But, those women I talked about who said it wasn't the worst thing that had happened to them, there were some women, we had very, very good interviews, African-American interviewers who were well-trained. And what came out a lot was childhood and adolescent sexual abuse, too, that women hadn't dealt with, compounded by the breast cancer. Most women had chemotherapy or radiation therapy. Actually, the burns from radiation can be a problem. We saw that. But at first, some of the interviewers were worried about invading, women at a time that was sensitive. And we went to their homes or wherever they wanted to be interviewed. We also interviewed homeless women, a lot of homeless women, wherever they wanted to meet us. But what happened was women would say, this is the only opportunity I've had to talk about it with somebody who I don't have to buck up in front of, I don't have to be brave in front of. So the interviewer said, actually, she wanted to know if I could come back before 6 months because it was somebody to talk to. So we try to follow the women. I don't know if you know who Rick Kittles is, but he's an African-American human geneticist who was on the the early Skip Gates ancestry shows. He's the one who told Oprah that she wasn't Zulu, which he said was politically difficult. But that's just an aside. Anyway, so we decided to once a year have a Valentine's party for all the women in the study, just to sort of give back. And Rick would come and just talk about the genetics of African ancestry, and we'd do roses and champagne. We tried to sort of give back to women who were, they're going through tremendous amounts. Can you even imagine that the breast cancer isn't the worst thing that's happening to you? So I'm not sure if I answered your question. But we certainly also, since these were social work master students doing the interview, they were often in role conflict over research and kind of, providing services. But we had laminated services. We were working with community partners in Chicago to try to provide services to women as they became, the need became apparent. And we referred, my husband was the medical director of Community Counseling Centers of Chicago, or the chief clinical officer or something. But we referred to them. And so just trying to provide as many services as we could to women who were so generous to share their stories. Did that answer your question? You can ask me more later.
How you doing, ma'am? I wanted to go back to St. Louis because I'm an elected official in St. Louis. Now, I've been elected official for over 10 years. and I've worked for the Congressman, Lacey Clay. I've worked for Charles Quincy Troop, and I also worked for the mayor as the assistant to the chief of staff. And I also worked at People's Health Centers for a number of years and helped with their expansion. I also worked with La Clinica back when it was La Clinica, and remember doing the mobile health van with La Clinica. I've also worked with Jorge Rio Pedre. I'm also a member of the Hispanic Leadership Group, and I hadn't heard of your program. And I'm sorry I hadn't heard of your program, but I want to make something clear. I'm extending an olive branch to you because it's disappointing to me to hear those types of things said about the city I love. And I'd be willing to work with WashU. I don't want to see the disparities in breast cancer for women. I've worked with Cheryl Jackson. I've helped a lot of women get their services on the federal level through the Congressman's office, Congressman Clay. And I know he's committed. I know that the elected officials are committed. I worked with Will Ross. I worked with Dr. Rainey. So I don't want people to get the impression that St. Louis is difficult to work with. We just need to meet each other. We need to talk to each other. We need to become aware of each other. And I think that that's going to make the change
and
to improve health equity.
This is being recorded. I won't say it. But we haven't always done our part. So I appreciate that greatly. And we're trying to be as humble as we can. Yeah.
This is a question for Dr. Mathews. I thought one of the really interesting and intriguing parts of what you're doing with Casa de Salud is what you call the navigators. Having been part of the financial struggle at La Clinica, I'm just wondering how are those volunteers? How do you fund someone to accompany the patients?
I love real questions, so I'm going to give a real answer. There are people in the room who have more updates on Health Literacy Missouri than I do. So the initial funding for the Navigator program came from Health Literacy Missouri via SLU, because it was such a large grant that when CASA was forming, the decision was to run it through Family and Community Medicine. All I know from where I sit is that there's been a lot of transition for Health Literacy Missouri. As I understand it, they've just selected a new director. But because we could feel that uncertainty, we have been looking for other places to get the Navigator program funded. So we've had one partner, and this partner actually had offered to, don't tell MFH this, had offered to fund the MFH project if MFH didn't fund it. So I still don't have a yes, but that's someplace we're looking. I guess I'm thinking back to our first speaker's comments this morning. It's how we choose to spend money. I am on the Barnes Jewish Hospital Community Needs Assessment group, and we, as a group, we put access as the #1 issue still in St. Louis. And it's not just, can you call and get an appointment in 2 weeks? It's like, how do you get in? So do I know for sure? So we have, very specifically, we have two staff navigators, and then we've had volunteer navigators. We do like to work with students, but that gets difficult because students have their primary responsibility of being students, and a lot of the hardest navigations are going into urgent care in the emergency room. I mean, those are the most traumatic things for someone to have to do, and so then we're typically using our staff navigators. We have a full-time Vincentian Corps volunteer who does navigation for us, and then Maria in the back of the room has done navigation as well. So the question, and so as we've looked ahead, we've wanted to make sure we do have staff capacity on navigation because it's so important. It's also the one part of what we do that, from what we hear back, our partners welcome most. So even though sometimes we'll bring uncomfortable information back to other organizations, what I get from some of our main partners is, we wish you would navigate all our patients. One of our main partners, she and I don't know if this will work, but she and I spoke yesterday about a collaborative opportunity, and she said, oh my gosh, okay, so we could do the prenatal and the behavioral health for women with postpartum depression, but if they need to go to legal for a U visa because they're in a domestically violent situation, or if they need to go to a shelter, could you guys do that? So here's something so valuable, and I know, the way Harold Freeman tried to approach navigation at the federal level was to get funding to research it. So this is one of those opportunities, because then that would build the case. It would build a case for funding it. This is one of those opportunities where our show rates with navigation are hugely higher than the baseline rates that our partner organizations get, and yet you're right. We're having to look and look and look, and where are we going to get long-term funding for this? If you'll join me in thanking our speakers, I'll be around for all day.